Welcome to the new Retina Radio Journal Club with Vit Buckle Society. My name is Rebecca Soares, and I'm coming from New England Retina Consultants. And I'm joined today by Matt Starr from the Mayo Clinic in Rochester, Minnesota.
Hey, thanks for having me. I appreciate being here.
And I'm also joined by Nikisha Kothari from Texas Retina Associates in Dallas.
Hi, thanks so much for having me.
Thank you so much both for being here. Today we're discussing a paper entitled Risk Factors for Meeting Criteria for Switching from Bevacizumab to Aflibercept when Treating Eyes with Diabetic Macular Edema and Visual Acuity Less than 20/40. It was a fantastic paper, what a mouthful. It was done by authors Chirag Javari et al. And the DRCR Retina Network. And it was published online in Ophthalmology Retina in February of 2024. I think it's helpful for this article, before we dive into the study itself, to give a quick background on Protocol AC. So the DRCR came out with Protocol AC, which assessed treatment for center involving diabetic macular edema with starting visual acuity worse than or equal to 20/50 by comparing two groups, bevacizumab first, with a switch to aflibercept if there was a suboptimal response, and then aflibercept monotherapy. And broadly, the conclusions they reached were that bevacizumab first treatment had similar outcomes to aflibercept monotherapy, even despite the switch. And regardless of the similar outcomes, about 70% of patients in the bevacizumab first group switched to aflibercept. So there's quite a few number who switched, but similar outcomes in the end. So I think that's a good background to have as we dive into the study. I'm going to pass it over to Dr. Starr. Dr. Starr, would you mind giving us a summary of Javari et al.?
Yeah, no, it's a great paper, and I think a little more background about Protocol AC and the switching criteria is pretty strict. I think in clinical practice we wouldn't utilize all of these criteria, but in order to be actually switched from bevacizumab to aflibercept, the patients had to have persistent involved DME, so meaning they actually had predefined thresholds met, and they were greater than those predefined thresholds. They had to have at least 2 previous injections of bevacizumab, and they had to have no improvement in their eye condition, and they defined that as no improvement greater than 5 or greater than or equal to 5 letters on the ETDRS chart, or as well as they didn't meet a 10% improvement on the CST thickness on OCT. And then lastly, they had to have suboptimal vision, which they defined as 20/50 or worse before 24 weeks, or 20/32 or worse, 78 letters at 24 weeks or later. And they had to meet every single one of those criteria in order to be switched. So those are pretty strict, and in clinical practice we may not utilize that strict of criteria. And then so jumping to the paper, the paper talks about this was kind of play on Protocol T, when was there a difference in 20/40 or better, or and using Avastin or bevacizumab versus aflibercept. And so this is kind of that version. Was there perhaps anything that could lead to improved outcomes? And so then they wanted to find out, are there metrics that we can identify that would maybe predispose someone to actually become being what they would call a switched patient. And so in this study, there were 270 participants with one or both eyes that met the predefined diabetic macular edema and visual acuity score. In the bevacizumab first group, there were 154, and then in the aflibercept monotherapy, there were 158 patients, or eyes, pardon me. And so, like I said, the objective was to identify factors meeting those criteria, and if there was any sort of baseline metric or metric before or after 12 weeks that may identify someone who is at risk for switching. And so, as Dr. Soares alluded to, there were a lot of patients in both cohorts actually that switched. In the bevacizumab first group, there at 2 years, 70% ended up switching to aflibercept. And interestingly, what I think is a really kind of underrepresented bullet point from Protocol AC is that even those patients who are in the aflibercept monotherapy group, at 2 years, 30% of those patients actually met criteria. So there's potentially 30% of patients who are not responding to, at the time, one of the best agents or individual agents that we can give the patients. And so what the study nicely did is they took all of the metrics and utilized a Cox proportional hazard model, logistic regression models, and tried to identify any sort of baseline characteristic. And essentially, after multivariate analyses, really the only thing that was just really associated with the high risk of switching agents was after 2 years was an older baseline age. At 12 weeks, having worse baseline vision, male participants as well also had a higher risk of meeting switching requirements. Thicker CST, as we would expect at 12 weeks, was also associated with an increased risk for meeting the switch criterion. Interestingly, the presence of an epiretinal membrane was also associated, but not statistically significant for meeting some of those switching criteria. And so there's a little bit of potential signal there, but after multivariate regression analyses, that did not come through. And so, age, in some cases, baseline vision or gender may be used to assess a patient or an eye that may meet the switching protocol criterion in a patient who's initially started on bevacizumab and then later transitioned to Aflibercept. And then when you're looking at patients or non-responders, those eyes potentially, as we would expect, would have a higher risk after a few injections or 12 weeks switched in the future.
Thank you for that excellent summary. Dr. Kothari, do you have any reactions to this paper, initial thoughts?
Yeah, I mean, I thought this was a great paper. Really, the purpose of this was to see if there's any risk factors we can associate with a higher rate of requiring to switch to Aflibercept. So overall, I thought it was a great paper. It gave us some clues as to what might be risk factors, and we'll talk about some of the limitations. But overall, I thought it was well done and good to have these risk factors in our minds when we're treating patients.
Yeah, I definitely agree. It's definitely an enlightening paper, sort of helps to elucidate in my mind kind of who might be at risk for switching. I also think it helped me think a little bit harder about the AC results and sort of in my mind figure out what that means in terms of who I consider to be a high risk patient. Dr. Starr, any more thoughts on Dr. Kothari's points?
Yeah, I mean, the biggest thing is really when you look at it, like level of DRSS, A1C, ethnicity, subretinal fluid, duration of diabetes, things that we typically think of as markers for potential worse diabetic retinopathy scores, really didn't kind of pan out in a multivariate regression analysis. And it's tricky. We've looked before on other things, looking at patients with persistent swelling or persistent fluid and fluctuations in fluid, and a lot of it is systemic disease, age of patient, and those are the biggest things. And I think that's what I kind of took home is when you really look at everything, it was your non-responders. So essentially those with persistent fluid after 12 weeks were more likely, which makes sense. And then the older age is tricky, but certainly I think patients who are older could potentially be a suboptimal responder.
Yeah, I think those are very great points. We'll take a quick break, and then on the other side, we'll hear more discussion about these results. We'll be right back.
Support for this program is brought to you by Genentech, the makers of Vabysmo, Faricimab SVOA. Now with 2 years of data. Want to know why specialists across the country are starting with Vabysmo? Visit Vabysmo, VABYSMO-HCP.com.
All right, welcome back to the new Retina Radio Journal Club with Vit Buckle Society. Let's get into a little longer discussion about the paper that Dr. Matt Starr has summarized in the first part of this episode. So I think it's a really interesting point that you brought up, Dr. Starr, to sort of consider which factors put people at highest risk for switching. And I think you said it very poignantly that it's often just the non-responders. We have all these factors that we often consider to be at greatest risk, someone who's had diabetes for a very long time, someone who has, someone who has a really high A1C, and they looked at all these factors, and really the main risk factor was just poor response, greater CST. Was that surprising to you? Was there anything that you think that they missed in terms of risk factors?
Yeah, great question. I think surprisingly, with all the metrics that you looked at, you think you'd find some more, statistically significant findings, and really it wasn't a whole lot there that kind of came back. And as we were kind of talking about offline, there's a couple of different things. When I think about it, it's kind of encouraging. It's really in a sense, it's hard to know who's going to do well or who's not going to do well. The study does shed a little bit of light on perhaps it's an age, maybe dependency. We do often think that young patients do pretty well when we treat them, and older patients perhaps do poorly. I would have liked to maybe see some systemic risk factors. It has definitely been shown that hypertension, kidney disease, they can really play a role in patients who don't respond to treat our typical treatment.
Yeah, I think those are both, those are all great points, those comorbidities that might not have been tested here. Previously you mentioned that you felt like the AC criteria were very strict. How so? What about the criteria felt strict to you compared to your clinical practice?
I mean, yeah, so when I see a patient with diabetic macular edema, and as an aside, I almost always exclusively start with Avastin or Bevacizumab, and it works really well. This study protocol, not this study, but protocol AC kind of validates some of that, in that if you start with Avastin, you still have similar visual outcomes. If you have to switch to a different agent, notably Aflibercept. And however, when I'm injecting patients and I treating them, if I really don't see a response in the OCT, that I'm really, unfortunately, the way it is, I'm guided by kind of that image. And if I see maybe some vision improvement, the patient's happy, I would, even if the OCT doesn't change a whole lot, I'm more inclined to kind of switch. Or this protocol AC criteria, they had to meet it's pretty strict in that they meet 4 criteria, and one, that it's not getting better, and that makes sense. You had to have persistent injections. I usually will do those those 2, but then having to have both a visual acuity improvement, or not meeting a visual acuity improvement, as well as not meeting a CST threshold improvement, and then also just having worse vision. Those are things that meeting all 4 is kind of strict. I think a lot of patients may be doing well 20/20, but they're still 20/20 -2, 20/20 -1. They're complaining. Then there's a big central cyst on OCT. I'm probably going to try something different. Conversely, these patients that we're treating and really trying to get better, we may just not be able to meet all 4 of those, and we just feel it's in our best clinical judgment to try something different.
Yeah, I definitely think in a trial where there's such strict criteria, it doesn't leave room for more real world kind of general clinical practice patterns. You're right. Meeting one of those criteria or 2 of those criteria is something that we all do in clinical practice, but meeting all 4 is a very strict requirement. So it'd be interesting to see real world studies based on switch patterns at the end of the day. Dr. Kothari, do you think that central subfield thickness is the appropriate metric here to be using on OCT?
I definitely think it's one of the metrics. I think, not surprisingly to any of us, CST made it more likely to switch. But I do think in the real world, we're going to look at other factors too. We're going to look if there's hyperreflective foci. We'll look if there's drill. We're going to look at other OCT features that might push us towards switching to a different agent earlier. So I think it's probably one good measure, but in real life, we probably use a number of things to determine who to switch. And like Dr. Starr mentioned, it's also based on what the patient's telling you. And it's, medical care is a conversation with the patient. And so they're going to ultimately help us guide our management. If they're symptomatic, like we mentioned, we're not going to use all 4 criteria necessarily to switch them. So I think it's a combination of things that kind of help us to guide our management.
Dr. Kothari, would you change your clinical practice based on AC or based on this article in terms of what you would start first and whom you would switch?
I similarly start patients on bevacizumab like Dr. Starr does. And so that part has not changed my clinical management. Oftentimes insurance is going to dictate our 3-step therapy with bevacizumab before being able to switch to a different agent. So sometimes I will switch later for that reason. I'll certainly keep in mind these risk factors, though, especially I found age to be a very fascinating one, and something that I think previously I didn't think of when evaluating these patients. And so, yeah, I do think that will play somewhat of a factor. The CST and visual acuity was less surprising to me. And then, gender plays some role, it seems like, here too. So something to keep in mind. I don't know that it's going to directly impact a single patient's management, but something to keep in the back of our minds when determining when to switch.
Yeah,
Yeah,
I think
I totally.
good points. I mean, I really was interested also in, the Aflibercept monotherapy group, like the patients that were perhaps getting, great treatment or, better treatment, if for lack of a better word. And why did 30% of those patients meet the switching criteria? And it's pretty similar, the age, worse baseline vision, worse baseline CST, and epiretinal membrane formation was an interesting one. That kind of makes sense. And so maybe there is a tractional component, and perhaps it is that some patients with an epiretinal membrane we're still treating with Aflibercept we call non-responders. And we maybe ought to consider trying something different for those patients.
Yeah, I think those patients with epiretinal membrane sometimes, surgical approach along with possibly a steroid may be the better route to go. So definitely something interesting, but whether they're true non-responders is arguable.
I obviously think one of the limitations here is that it's a post hoc analysis. So again, I'd be so interested to see these results kind of on a bigger scale or more real world scale. Well, we look forward to seeing more results like these from DRCR network, and we look forward to sort of the next analysis about what we should switch people from Aflibercept to once they no longer meet criteria.
Yeah, I think
well,
the
thank
big
you so.
elephant in the room is like steroids, and like what can be done there.
Yeah.
That'll be really interesting. But like you said, it's a retrospective analysis on something that wasn't meant to be analyzed, and so take it with a grain of salt.
Right, exactly. Yeah. Well, thank you so much to the panelists, and thank you for listening to New Retina Radio Journal Club with VBS, and stay tuned for further episodes. See you around. Thanks so much.